So I heard an interview this week with Chris Hadfield, who was in Vancouver doing interviews in his former role as the Canadian commander of the International Space Station. And always fascinating to hear him talk, but in particular, he mentioned how wonderful it was to have the opportunity to take a different perspective on things. And in this case, his opportunity to look at the world from up there versus down here. And while on a very different scale, I'm very thankful for the invitation to do this lecture because it provided me with an opportunity to push back from my desk and to take another perspective on the work that I've been doing for the past 10 and 15 years, to take a big picture view. And so thank you very much for this opportunity to share my experiences with you as the researcher in a research policy partnership, and in particular in the role around work and health and workers' compensation. So the point of this lecture is to share what I've learned on how a research policy partnership can work, and in particular drawing examples from the Partnership for Work, Health and Safety, how to access and use big data that will have a policy impact. And here I'm drawing on the example of Population Data BC. What is research evidence for policy making, and what does having an impact really mean based on my experiences? And finally, to take this opportunity to applaud the architects and builders of these kinds of partnerships and these kinds of models. And today I will be applauding Dr. Clyde Hertzman. The photo in this slide, it's not coming out quite as clear as I would like, but the photo was taken by Alexis Burkhill from the Point Atkinson Lighthouse in Vancouver as the International Space Station was traveling over Vancouver last week. And this picture was only made possible by blending together a series of snapshots at different points in time to paint the full picture or to provide this full picture. You can it's a little clearer in other formats. You can see the space station kind of streaking across the sky. It is my hope that by providing you today with different snapshots at different points in time of projects that I've been involved in, that you will get a full picture of my experiences with partnerships, with public utility models for data access, and for policy impact. A couple of caveats before I continue. I will use the term policy interchangeably with programs and procedures and processes, and I'll use the term policy makers interchangeably with decision makers. So I'm going to start first with what I've learned and what I think are the most important insights that I hope you take away with you. Just in case I run out of time, I'm going to give it to you first. So in a nutshell, for me, for research evidence to inform and impact policy, the researcher-policymaker relationship needs to be long-term and committed. Upon reflection, my experience has often been like maintaining a common law relationship. Research evidence impacting policy necessitates a continuous process in which knowledge accumulates and influences thinking over time. And finding a way to sustain this process and to support the continued interactions between researchers and policymakers is essential. Second, that big data, and by that I mean administrative data or data that was collected for an administrative purpose or a purpose other than research, but that can be used for research purposes, that big data matters for having an impact, in particular in providing population-based evidence in a local context that resonates with the policymaker, and in this case with the workers' compensation system. Supporting public access models to use this data for research purposes, in my opinion, is the way forward. And finally, that research impacting policy is both an art and a science. It was important for me to realize, after being involved in this partnership for more than a decade, to realize that policy and decision-making can be a creative and a messy process. It doesn't always adhere to any rules that I'm aware of. It can take many different forms, and it can be in the eye of the beholder. But at the same time, that existing evidence, existing science on models of policy and decision-making are extremely helpful. They were extremely helpful to me in facilitating the process and for understanding how evidence could have an impact. So, as I've mentioned, this talk will blend together a series of case studies or snapshots of research evidence and their policy impact as they evolved over time over the last decade in order to paint a picture of partnerships, public utility models of data access and policy impact. To do this effectively, I need to provide a bit of a backdrop for you to the Partnership for Work Health and Safety, as well as to Population Data BC, as two cornerstones of making all of these case studies happen. The Partnership for Work Health and Safety is a research policy partnership between the University of British Columbia and WorkSafeBC, the Provincial Workers' Compensation Board in British Columbia. Although that partnership now has tentacles throughout Canada and internationally. The purpose of the partnership is to maximize the use of the workers' compensation claim data to conduct policy-relevant research. And I use that term, the decision makers will use the term generating knowledge and evidence. And it was primarily in the BC context, around BC workers and the BC workers' compensation system. It started off as a very informal relationship, but now is formalized with a signed agreement between both parties, the university and the compensation system. At its core are regular meetings between senior executive at the compensation system at the level of the VPs and directors with the university researchers, faculty and research staff, to identify the research priorities and to ask whether it can be answered with the data in hand, to facilitate access to the data, to interpret the findings in the local context, and to strategize about how to disseminate the findings to decision makers within the organization. WorkSafeBC provides the infrastructure for this partnership. They provide the money and the data, and the research team uses that to leverage additional funding as well as additional relationships with decision makers and investigators to generate the evidence, and it also provides training opportunities for students. So Population Data BC is a public utility model for data access that enabled us to access the workers' compensation data, often linked to other databases for research purposes. So it is a model that allows access to the data for the public good. The predecessors of Population Data BC date back to the 1970s when a group of researchers were given access to the Ministry of Health data for health services research. And over the years, this has evolved to include other large administrative databases in education, cancer registry, the compensation data, and eventually to this public access model for the use of the linked data for research purposes in 1996. And that's accessible to researchers across Canada now. Population Data BC and its predecessors were designed to capture the power of linkable longitudinal data while avoiding the inefficiencies associated with project-by-project access and linkage, and to provide access to this data in a secure research environment that adheres to security standards and privacy legislation. So Dr. Clyde Hertzman was the original architect, and here I'm using both that word as a noun and a verb, of what is today the Partnership for Work Health and Safety and Population Data BC. So I want to take a moment to recognize his contributions. He was a professor in the School of Population and Public Health with me at the University of British Columbia, and for many of you in this crowd, a long-serving chair of the Institute for Work and Health's Research Advisory Committee. Clyde passed away unexpectedly earlier this year. Clyde's accomplishments are many, and it's very tempting at a moment like this, as a remembrance to him, to try to describe all of them for you so that you understand who he was. But perhaps they are best summarized by the recognition that he received when he was named as an Officer of the Order of Canada this year. And may we all have the opportunity to be described in such a way. The Order of Canada recognized his lifetime of outstanding achievement, his dedication to community, and his service to this nation, making contributions that enriched the lives of Canadians and made a difference to Canada. As with all things in Clyde's life, whether it was occupational medicine early in his career, occupational health, workers' compensation, and access to big data in his mid-career, or early childhood development later in his life, he did this with a vengeance and a vision. And if any of you have ever had the luxury of being in the same room with Clyde for a meeting or anything, you will know what that was like. Your life was never the same. While Clyde is not the focus of this lecture, it does provide an opportunity to remember that his footprints and fingerprints are all over the work that I will present, and that important and impactful research in the field of occupational health and safety and in workers' compensation was made possible by his architecture. In the beginning, way back when, the beginning of the research policy partnership between UBC, or the University of British Columbia, and WorkSafeBC, and the use of compensation claim data to inform policy and decision-making dates back to the Royal Commission on Workers' Compensation in British Columbia in 1997 and 98. This work represented pioneering record linkage of the workers' compensation claim data with data from the Ministry of Human Resources for information around income assistance and the Ministry of Health for information around health and healthcare utilization. And it was carried out to support the inquiries of the Royal Commission, including, for example, the following questions. What are some of the characteristics of the workers' compensation population with respect to their socioeconomic status? What is the pattern of use of health and social services before and after a reported injury? How do these patterns compare to a population matched by age and sex? And does workers' compensation operate as an integrated piece of the social safety net? This work was led by Dr. Hertzman and demonstrated proof in concept, demonstrating the ability and the utility of these data to inform policy-relevant issues and of the University Compensation Partnership to answer these questions. This ultimately led to an investment in making the compensation data available through a public utility model for research purposes through Population Data BC, and an investment in maintaining the researcher-policymaker relationship in the form of the Partnership for Work Health and Safety. So don't underestimate the importance of that building block, the proof of concept, and the need to invest resources to maintain and build a productive policy partnership. So, as I mentioned, the rest of this lecture will follow a chronological series or snapshots of research conducted by the partnership via Population Data BC. But I wanted to note that not all of the work that I will talk about was led by me, and I wanted to take this opportunity to give credit where credit is due to those investigators, research staff, and students who've led the work under the partnership umbrella over the years, some of which I think are in the audience. I also want to draw attention to authors of work on research use models for policy that have been particularly insightful for me and that resonate throughout this talk and that may be helpful to you. Work by Carol Weiss, Shelley Bowen, and Jonathan Lomas in particular. I feel it important to state at this point that the existing evidence on research use models for policy were largely written from the perspective of research rather than policy. This lecture, too, is from my perspective in the role of the researcher trying to get her research used, more than that of the decision maker trying to do the using. So, this first series of case studies. This particular project investigated the compensation of work-related asthma among workers in British Columbia. This was made possible by linkage of the BC Healthcare Registry to identify the working population, linked to healthcare records to identify individuals with diagnosed asthma, to a job exposure matrix on occupational allergens to identify those with asthma attributable to their occupation, and finally to the workers' compensation claim data. You will note a large proportion of individuals with work-related asthma are not presenting or were not presenting to the workers' compensation system. This was one piece of a body of evidence that informed a policy change in the occupational disease schedule recognizing work-aggravated asthma as a compensable disease in British Columbia. I'm not sure if Paul Demers is in the audience, but he started a lot of this work on asbestos-related research. This work, too, was looking at the compensation of occupational disease. Here, mesothelioma, a cancer primarily of the lining of the lung caused by occupational exposure to asbestos and universally recognized as an occupational disease. This study was made possible by access to and linkage of the cancer registry data, which is comprehensive for cancers in the province, to workers' compensation data for workers with a claim for mesothelioma. Less than half of individuals with mesothelioma have a workers' compensation claim. This is not the result of denied, rejected, or disallowed claims or claims covered under some other insurance type of policy. Rather, this is about individuals not presenting to the workers' compensation system for what is a known occupational disease and a known occupational exposure. To emphasize the point, evidence on the compensation of asbestosis demonstrated a similar pattern. Here, individuals presenting with a diagnosis of asbestosis to their physician or to the hospital, primarily not in the workers' compensation database. Asbestosis is a chronic inflammation of the tissue of the lung caused by the inhalation and retention of asbestos fibers. Evidence of asbestos-related disease and compensation, and in particular within the local context, so demonstrating to the local compensation system that this was an issue even in their own backyard, made and maintained this as a policy priority, providing support for the handling of sensitive claims at the compensation system, the implementation of an occupational exposure registry, and an intervention to try and reach individuals in the cancer registry with mesothelioma. So, what did I learn about partnerships, data, and having a policy impact? This series of studies was completed in the early days of the partnership, with researchers needing to take the lead on the priorities within the partnership. We expected the policy partner to know what to do with the research opportunity, but it was still a little too early for them to fully understand what could be done with the linked health data as part of the partnership to inform policy. But we were okay with that. In these early days, a critical factor in the use of evidence throughout the policy and practice pathway was the influence of individuals within the organization. And this may be counter to some of what you read about policy and having a policy impact, where they talk about the impact of the organization or the broader environmental factors. For us, it was about individuals. We had the benefit of dealing with a couple of individuals who were early adopters of this innovative partnership, willing to take some risk, active seekers of new ideas, and part of a highly interconnected social network within the compensation system. These early adopters were critical to our success, fighting for the longer-term relationship and the financial resources to maintain this. Late adopters were at the table, and it's helpful to note that they were influenced most strongly by evidence within their local context, so evidence using their own data, and by interpersonal contact, so regular communications and meetings. We also learned that a picture paints 1,000 words. The 3 pictures that I've shown you today were it. It was sufficient. They painted 1,000 policy words. In the research-policy relationship, we, the researchers, needed to overcome our unease with the simplification of the presentation of research evidence and the inherent uncertainty of the scientific activity in order to provide timely and relevant evidence. We also learned that the views of policymaking regarding what counts as evidence are broader and more encompassing than what the researchers were using. It includes consultations and history, the ideas and beliefs of experienced individuals within the organization, the politics and the economics, and that the policymaker prefers to combine all of these sources of information in policy development and practice. Researchers don't always recognize this or the other forms of evidence, nor do they always feel that it should be given the same weight as the other forms of evidence and information. So, starting these next series of slides or case studies, this evidence was generated in response to a recommendation from the Auditor General of British Columbia to evaluate an expedited surgical fee policy and the provision of surgeries in private clinics on work disability among injured workers in British Columbia. This work focused on knee surgeries as the most common surgery performed or covered by the workers' compensation system. This particular project required the internal linkage of multiple workers' compensation databases as well as to Ministry of Health data on medical services and hospitalizations. There were 2 windows of interest highlighted here in the red in terms of the effect of the surgical incentive fee on the window from consultation date to surgery date, and both the fee and the surgical setting interest in the return to work window from surgical date. The results showed that the wait time incentive worked, although it was not being implemented as per the policy. But it did reduce the time window from surgical consultation to surgery, on average about 2 weeks. But there was no effect of this or of the surgical setting on the disability duration post-surgery. And in fact, surgeries performed in individuals who had surgeries performed in public hospitals returned to work faster, had the shorter disability duration window. As some of you may know, tree fallers have the highest serious injury rate, including fatalities, of all occupations in British Columbia. A certification standard was introduced in 2003 that you needed in order to work as a tree faller in British Columbia. This became a mandatory requirement in 2006. It includes classroom training, practical training in the field, so many hours of training, as well as having to take an exam and a practical exam to be certified at different grades to work in the industry. Evidence of the effect of certification on work-related injury rates required linkage of longitudinal, historic, workers' compensation claim data to cover this period, linked with the external faller registry maintained by the BC Forest Safety Council, and with industry data from the Ministry of Forests and Range. The evaluation showed no evidence of an effect on the injury rate, but it also revealed that the majority of experienced fallers in the province had been grandfathered into the certification process, had not fully participated in all of the requirements. So what did we learn now at this stage? This was about the midway point in our partnership, and the priorities or the agenda, in this case primarily focusing on the evaluation of policies and procedures, was now being driven by the workers' compensation system. They were asking us to respond to key knowledge gaps and evidence needs within their organization. The public utility model for data access enabled us to access this sensitive data, so sensitive data on surgeries, and to link this to external databases, so partners outside of this partnership. and enabled us to do this in a secure, confidential, and a privacy-protected manner. Part of building a successful partnership and being asked to evaluate these kinds of sensitive policies was predicated on an agreement not to release the findings, but no restrictions on publication of findings by the researchers after this holding period. So this recognizes the challenges of releasing findings that may be controversial for the organization, while at the same time the potential value of peer-reviewed publication as an external validation of evidence. So we were fine with this holding period and allowing the organization time to review and to plan for the implications of the findings. While the evidence impacted how the policies were implemented, it did not result in major policy shifts, or new policies for that matter. The evidence from this work illustrated that there are different models of the use of research and policy making that are applied at different points in time. It was helpful as a researcher for me to recognize this, although perhaps this is more intuitive for the policymaker. I naively expected that the empirical evidence from the surgical weight fee and surgical setting study would lead to a direct policy change. In other words, a knowledge-driven model or a problem-solving model of policy change. But in fact, what happened was more reflective of a political model of policy change. In this model, decision makers are receptive to research that serves more of a political purpose. That is, demonstrates proof for a decision or evidence to justify a decision. In this case, policies were perceived as meeting a need and not doing harm. Also at this phase, starting to recognize that research evidence has different impacts, including for us, setting, informing, or maintaining priorities, developing new or shifting policies, although that was not as common, and we need to be realistic about that, and also for monitoring and modifying existing policies. In the words of Carol Weiss from Harvard University, it depends on what you mean by impact. If you mean that research causes a specific piece of legislation to get passed, that's not very common. A principal use of research for policymaking is conceptual. Research evidence is considered less as problem-solving than as a process of discussion or debate, or a way of thinking about an issue, not an instrumental tool defining and then determining the right solution to a problem. These words offer a longer-term view of the impact of research evidence on policy. So these next series of studies will acknowledge led by Chris McLeod and Kim McLeod, not related, in the partnership. In BC, employers that successfully implement a safety management program and meet a set of audit standards can earn certificates of recognition, also called CORE. Although this is about fostering a safer and healthier work environment, WorkSafeBC also provides a financial incentive to core companies in good standings based on their assessable payroll and the premium rate at the time. This research involved access to new to us firm-level data to evaluate the impact of participating in the Certificate of Recognition program, demonstrating a positive impact on the workplace injury rate and claims rate over time. Along a similar vein, this particular research involves access again to firm-level data to evaluate the impact of workers' compensation activities, for example, inspections, citations, on injury rates. So what have we learned from this series of studies? This partnership work is now entering a stable and trusted phase of the relationship. Research priorities are a mutual decision-making process, but clearly involve activities at the core of the organization's mandate in terms of things like inspections and their certificate of recognition, sensitive areas of policy relevance to the compensation system. It also now includes a reliance on the researchers to bring expertise to the analyses of the compensation data. Using, for example, illustrated here, the differences in differences approach to evaluate policies, taking into consideration baseline differences with a comparator, using econometric methods to account for workplaces with zero claims at different points in time. These new areas of investigation and evaluation highlighted for us the importance of determining capacity to act on evidence. And for us, capacity is having the right people at the table. Those right people put us in contact with others to support the generation of the evidence and the uptake of the evidence in the policy and the practice pathway. So the final series of case studies representing a little bit of innovation in the research agenda and focused on disability duration. Chris McLeod is again spearheading this work, a comparative research agenda to investigate differences in compensation indicators that may be related to variations in policy and practice in different jurisdictions. Although jurisdictions with similar approaches to compensation and within similar socio-political and economic environments. Here, for example, the state of Victoria in Australia and the province of British Columbia. This preliminary graph, which was providing proof of concept in the early days, actually provided evidence of the impact of a 10-day waiting period for workers' compensation on disability duration in Victoria. So delaying people who might have returned to work at 1 day or 5 days, waiting until 10 days. This 10-day waiting period is not present in BC. The graph has already been a source of discussion and debate and enlightenment to our compensation system, who have been talking about this issue of a waiting period and demonstrating perhaps that it's got unintended consequences in terms of delaying disability duration or return to work. Also related to disability duration, we are investigating gender differences in the disability duration of workers' compensation claims. Illustrating here for you acute injuries such as fractures, although we've also looked at strains and sprains, although not shown here, that women are taking longer to return to work than men for workers in the exact same occupation for the exact same injury. Both of these projects represented novel areas of investigation and research methods. In the early phases of the research policy partnership, the policy partner was not receptive to these ideas. And only after developing a longer-term trusted relationship were they receptive to participating in these kinds of projects and using their data for these kinds of innovative questions. But early on, not comfortable with the comparative agenda, not sure what to do about looking at gender differences. The research opportunity presented itself in terms of the need for evidence on disability duration and at a point in time where there was this established trusting partnership. I'm going to finish with a discussion of public utility models for data access and a summary about what I've learned about partnerships. I focus here on the public utility model again offered by Population Data BC, but there are other models across this country illustrating access to data for research purposes that is in the public interest, including, for example, access to Statistics Canada survey and census data via their research data centre model, access to Ontario healthcare utilization and other health data via the Institute for Clinical Evaluative Services, and access to health plus education, social services, justice data via the Manitoba Centre for Health Policy's Health Research Data Repository. All of these public utility models have taken a slightly different approach to making data available, but include common elements. Those common elements include an access policy or requirements. Some of them requiring researchers to be part of a bona fide research institute in Canada, others requiring researchers to become employees of the institution, and others still requiring a collaborative model where you work with investigators from their institute or organization. They also all include some form of a review process by the data stewards, those people who originally collect the data and get a say on how it's used. This is through application processes or proposals for review. They all also include some form of accountability. These take the forms of signed research agreements or confidentiality agreements, and also this holding period for a chance for the data steward to review the research findings. They all include some kind of a cost recovery or fee-for-service model to support the infrastructure needed to do this, and access through some kind of a secure environment. In BC, it's a secure server through a virtual private network with a firewall and security IDs, and in other instances, it's satellite offices that adhere to the security and privacy legislation required for access to sensitive data. All of them achieving varying levels of a streamlined, harmonized, and transparent access procedure for applying for data that adheres to privacy and confidentiality legislation, and that ultimately serves the public interest in terms of health policies, or generating evidence for health policies. In summary, it's all about the relationship for me, and figuring out how to facilitate and maintain this relationship to generate evidence to have an impact on policy. In our case, or in my experience, this was starting with proof of concept, leading to a partnership agreement that in turn led to regular interaction resulting in relevant evidence in a timely manner. I want to finish by talking about how I found interaction models for research impacting policy to be particularly helpful. Here citing the work, for example, of John Lavis and Jonathan Lomas. Paraphrasing their work. The policy-making process is one of ongoing and often prolonged interaction between researchers and the policymaker, from which may emerge feasible and acceptable evidence to inform policies and decisions. The policymaker does not rely so much on specific studies as on access to knowledge through trusted and ongoing relationships with the research community. For researchers, the tools for research use are structures that routinely link the researchers with policymakers and the decision-making process. That's what we gain out of that. However, researchers are warned not to expect great leaps forward in policy, at least not immediately, but rather to recognize the different types of impact that research evidence can have on policy, including things like priority setting, discussion, enlightenment, monitoring, and modifying policies. The interaction models draw attention to the importance of interpersonal factors in the policy world and the need for the long-term investment in social structures and processes to maintain this. So if you want more detailed information on any of the studies or research evidence that I've covered, you can find that through our website and links to reports and publications, and you can also feel free to contact me or anyone of the partnership team. And I thank you very much for your attention.